Welcome to the Dr. Geo Prostate Podcast. Today's guest is Dr. Matthew Cooperberg, a top expert in focal therapy for prostate cancer. Dr. Cooperberg is a professor of urology and epidemiology at UCSF and an internationally recognized leader in prostate cancer detection and treatment. In this episode, we explore HIFU, high-intensity focused ultrasound. You'll learn what it is and how it works, who the best candidates are, whether it's an option for more advanced cases. Let's get into it.
Before I proceed, I just want to clarify that this podcast and all Dr. Geo content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Geo Prostate Podcast. I'm your host, Dr. Geo, looking to help you, inform you, empower you with information around prostate health, prostate cancer, overall wellness, and how to live better with age. My guest today, the one and only Dr. Matthew Cooperberg from UCSF. Matt, thank you so much for being on and for accepting this invitation.
It's a pleasure. Good to see you.
Good to see you. One of the things we were talking before we began recording on the podcast is doing very well and along those lines. And I got to tell you that from my end, and yeah, I love the numbers when they go up, more viewership, more down, love it. One of the things that excites me the most is that I don't think I would talk to people like you that much if it wasn't for the podcast. Because where, how? Everybody, AUA, everybody's running around like a chicken without a head. Yeah. Conferences. We're not just going to meet up out of the blue as we barely know each other. So through this podcast, I'm able to all, in my opinion, elite in the field. And I think that's that's the biggest joy for me. So again, and I appreciate your time for doing this.
That's great, man. It's a pleasure, really a pleasure. And congratulations on the podcast success. It's terrific.
Thank you. So focal therapy.
Yeah.
AUA 2025 plenary. I was like, whoa, this is going to really blow up. All the focal therapy booths at the AUA. I always gauge how well they're doing based on their size of their booth. And most of the booths associated with a certain type of focal therapy was much bigger than it was last year. So I'm making the assumption that things are going in that direction and is gaining ground. So I think that now, in my opinion, based out of this past meeting, that focal therapy is going to get to the next level now in terms of more users, more practitioners, more demand from patients. So we've had several episodes in the past on focal therapy. But if you don't mind, what's out there today, giving us a little bit overview, the different energies, why does it matter? Why the different energies matter for certain tumors, location, those kinds of things. So why don't you go at it?
Sure. So, this is obviously a hot topic, as you say, all over the AUA, lots of developments, new energy modalities, et cetera. Although I think a lot of the important work in focal therapy still is in defining the right candidates for focal therapy and figuring out how and when to bring an energy source to the problem. I think on balance remains the more important question than which energy modality to use. There are definitely some thoughts out there about different modalities potentially being better for tumors at the apex, for example, or those close to the urethra. But I've always had the sense the bigger question is, do we know what volume to treat? We have a variety of ways to destroy prostate tissue. The question is, do we know what it is we're targeting? Do we have the right imaging? Do we have the right sense of the tumor from biopsy, et cetera? We can start anywhere along those questions.
But how is the imaging? Is it getting better? Is the future brighter? Depends on the company, depends on the technology, because it's just common sense, right? The better you can see what you're going to hit, the better you have a chance of actually hitting it.
Yeah, without question, right? So the whole notion of focal therapy, obviously, is treating an area, a discrete area of the prostate, leaving the rest of the prostate alone, and thereby hopefully generating fewer side effects than traditional whole gland therapies like surgery or radiation therapy. So the question is, do we know with good confidence what we are treating? Now, the term focal is used pretty broadly. I think we talked about this last time. Anything from treat just the tumor on imaging, to treat the tumor with some halo, some margin around it, to hemiablation, so treat an entire side of the prostate, to treat an entire side plus some of the other side, kind of leaving only the other nerve bundle behind. And all those things are to some extent subsumed into this rubric, this category of focal therapy. So it's important to make sure we're talking the same language. A lot of the progress that's been made has been in imaging. In the very early days, you would do focal therapy just based on biopsy, say, well, the biopsy was positive at the right apex and mid, therefore that's the region we're going to treat. I think we have more confidence in imaging today than we did 10, 15 years ago, but there's still a lot of questions about how accurately we can define the volume of the tumor with traditional multiparametric MRI, for example. And there's definitely a sense that the higher risk the cancer, the more likely it is that the MRI might be undersampling the cancer. So empirically, we see more contralateral high-grade cancer, for example, in areas that are not within MRI visible lesions, if this is a high-grade cancer, compared to sort of an optimal focal therapy case, which we think of as a grade group 2, MRI and ultrasound visible without much else on the other side. We will happily not treat 3-3 on the other side, but we want to make sure we don't have bilateral high-grade disease. So there's a lot of questions about defining the target volume, because everybody's seeing reasonably high recurrence rates here. Everyone that's doing a lot of focal therapy and is honestly tracking their data and doing one-year biopsies, which you definitely need to be doing in focal therapy, everybody's got much higher recurrence rates than we would see with surgery or radiation therapy. And that is okay from the standpoint that we're not burning bridges. We can always come back and do surgery later. We can do radiation later. We can do more, another round of focal therapy. And those are all relatively straightforward compared to the prospect of doing salvage therapy after radiation, for example, in terms of, is it more difficult to do second line treatment? It tends not to be after focal. So everybody is more or less okay with these high recurrence rates, but we would also very much like to see them be a lot lower. So the question is, when we see recurrence, is that because we did not get enough energy into a volume? We didn't heat or cool the tissue enough? Is it because the volume was too small? Or is this just biology? The prostate that grew one tumor is growing another tumor. And all of those are probably playing into it to some extent or another.
Does the genetic testing that's utilized, in this case, I think the most common is probably still the Decipher score.
Yeah.
Does it help you determine? So let's say you have a Gleason grade 2, but it's high risk on a Decipher. Does that change your treatment approach?
Yeah, that's a great question. So how exactly to use genomics in the setting of focal therapy is totally an unanswered and evolving question. We are trying to collect Decipher data on almost everybody we're doing focal therapy on, both at UCSF and across a 5-campus University of California consortium we've organized, because we want to answer exactly those sorts of questions. My colleague Hao Nguyen at UCSF with one of our residents, Kevin Shi, has a paper coming. It's been presented as an abstract so far, suggesting that Decipher does tend to predict a higher likelihood of recurrence after focal therapy, which certainly makes sense. I don't think we're at the point of saying you are ineligible for focal therapy if the Decipher is high, but that's definitely one that we're going to be more concerned about. We have to cancel the patient. The likelihood of recurrence or of a second tumor is certainly higher than if the Decipher is low. Eventually, we may get to the point where we have solid data that there is some threshold of Decipher or some other genomic marker that would, really predict a poor response to focal therapy, and that we should counsel that patient to do something else. But we're not at that point yet. So we're definitely collecting the data. And again, we follow maybe a little bit more carefully, but I wouldn't rule somebody out today just based on the genomic test. Now, if they're already borderline, meaning they've got a pretty high volume, grade group 2, we see adverse histology, so expansile cribriform, intraductal patterns, for example, and it's a relatively large tumor. There's any question about ECE or PIRADS5, and then we get a high Decipher on top of that.
Extension is ECE for the audience.
Yes, sorry. We can come back to that in a second too, because that gets back to the imaging questions. So if we have these types of risk factors, and then we layer on a high-risk Decipher on top of that, this is somebody that we're going to start to say, listen, we can do focal if you really want, but it is almost certainly a question of when, not if, we're going to come back and do something else.
I think so. A lot of my patients, so we share some patients.
Yeah.
And I love to see a study on a GG2 that's localized, even if it's high, particularly if it's high risk Decipher, along with aggressive lifestyle interventions and see what happens, right? Because I do think that certain lifestyle interventions can create a microenvironment that's hostile to cancer cells. It's hard to prove. There's a lot of variables, and how do you know? Are you eating right? But not, there's a lot of variables. But those patients, and most patients with prostate cancer, they're compliant. They do what I ask them to do, 80% compliant, if not more, right? Because this is like the big C. So, you and I, we may not be as compliant because we're healthy. But once you get the C word diagnosis, like whatever you want me to do, doc. So I would love to see that kind of study, because that's actually how I present it. But also with the idea is, if I have it wrong, let's say I could have it wrong, well, you can always do something else, right? You could always treat the cancer. You can remove the prostate as well. So with regards to prostate removal after focal therapy, is not such an ugly procedure as it would be with radiation, is what you're saying.
Correct. So, when we go in to do surgery after radiation, there is fibrosis, there's scarring around the prostate, the extent of which is very hard to predict. So there are urologists out there that say it's impossible to do. It's definitely not impossible. I've done it many times, but it is definitely harder than doing the surgery in somebody that has not had radiation therapy. And the degree of difficulty ranges from, sometimes we go in and look and it's almost like nothing happened, like they forgot to turn the machine on in the first place. There's other times that we go in and it's like a bomb went off. Everything, all the planes are completely gone, and it's difficult or even impossible to get the prostate out following radiation therapy. With focal therapy, we don't see nearly as much fibrosis. There can be local scarring. It's a little bit more if there's been full kind of hemigland ablation. If somebody got bilateral ablation, that's a different story. Then there is a lot more fibrosis. And in some cases, it can be even worse than with radiation. So somebody that has had whole gland cryotherapy, for example, that's a big, that can be very difficult. But the typical patient that's had a discrete lesion treated, usually it's pretty straightforward. And likewise, we can go in with radiation therapy without compromising the effectiveness of the radiation if there has been focal therapy done. Get back to your point about diet and lifestyle, by the way. We've looked at that quite a lot at UCSF over the years in the context of active surveillance and peri-prostatectomy lifestyle changes. Not yet in focal. And I think it's a great concept, because there definitely are factors in the stroma, the microenvironment around the cancer cells, that we do think affect its likelihood of coming back or surviving the focal therapy. But I'm not aware of any studies ongoing yet. But I think it would be a great space for that type of intervention. Patients in New York and probably San Francisco, I would expect, are a little more compliant with this sort of thing than in other parts of the country, which is one of the challenges we've actually had in San Francisco. Is a lot of the patients that we try to get onto these studies are doing too well at baseline. They're already too active and eating healthy diets already. So we got to find the ones who need the change.
You boring patients, you're coming in way too healthy. What's wrong with you guys? That's right.
Yeah.
I'll talk to Stacy Canfield on that, and maybe
exactly. Her and June Chen have really led this charge for us.
Tell us about the energy. So energy source, does it matter? Does it matter related to tumor? And what are the energy sources that are available today in 2025? I think it will change by 2026.
Yeah, there are many. So, and seems like there's a new one every year. There's probably the most venerable one at this point is cryotherapy, that is using ice to destroy the tumor. It is still quite effective. I think the pendulum has swung away from cryotherapy, mostly because of the technical issue that as the ice ball develops, so cryotherapy, you're literally creating an ice ball, and the idea is to give severe frostbite to that region of the prostate and kill the cancer that way. The problem is, as the ice ball develops, there's a big acoustic shadow. So we do this under ultrasound guidance, and you can't really see what's happening behind the leading edge of the ice. So we assume it's growing as a sphere, but you don't have a lot of control beyond that, that kind of estimating the volume of the ice based on the leading edge. So the field has moved toward modalities that are a little bit more real-time image guided. The one that we are doing the most of now at UCSF, and I think a lot of other centers, is HIFU, which is high intensity focused ultrasound. We're now into the third, maybe fourth generation of the equipment for HIFU. When I was in training, when I was a resident, this was a 4-letter word, HIFU, because the outcomes were really not good. There were a lot of practitioners around the state and around the country that were doing all kinds of slightly shady things, like taking patients to Mexico and Canada for cash treatments, with no legal recourse and things like that. There was a so-called California HIFU Institute in California. These folks that would treat absolutely anybody, high grade, low grade, overtreat low risk
Without a
disease.
biopsy.
That was not California HIFU. That was happening in some places as well. Yeah,
Florida,
there was a
maybe.
guy in Florida. Yes, yes. Brachytherapy without a biopsy too. Crazy. I mean, truly, literally criminal. So
Truly, I think
yeah,
if we're talking about the same person, he did some
yeah,
time in jail. Yeah,
he did. He certainly deserved time
yeah,
for that.
yeah.
So, yeah, all that sort of thing happened. I think in the modern era with the better machinery, first of all, we are being more thoughtful about who should be getting treatment, how we're tracking outcomes, and we're collecting data much more thoughtfully. So HIFU is using heat instead of cold to destroy the tumor. And the kind of conceptual advantage over cryo is that we do this under real-time ultrasound guidance, often with MRI fusion. So you're having the MRI information in advance. And this lets us control the zone of ablation in real time. We can kind of track it in relation to where the tumor is. And the better the imaging is, the more effective we think this is likely to be. So a number of centers are now using advanced MRI. We have a modality called restricted spectrum imaging that we've just started using. There's other centers using carbon-13 spectroscopy. There's a whole set of these to try to improve our ability to delineate the target for ablation. Now, there are still limits. We still try to avoid giving too much heat to the urethra or to the nerve bundles, certainly the rectum. And that puts some constraints in terms of how much volume you want to treat. And it does create challenges for treating some anterior tumors, especially in larger prostates, and especially the ones very close to the apex, where the urethral sphincter muscle is. So there is growing interest in a different modality, which is IRE, irreversible electroporation, which is using electricity to, like it sounds, basically to create little pores, little holes in the cancer cells and kill them that way. The theoretical advantage here is that it does not affect the cytoskeleton of the urethra specifically. So there's a lot of interest in using this explicitly for apical tumors. I've not done this personally. One of my colleagues here has done a couple dozen cases so far with what seem to be good results. I should say there are almost no head-to-head results for any focal modality over any other focal modality in terms of
Right.
prospective head-to-head quality of life outcomes, et cetera. So there's a lot of anecdotal this and that in case series.
Or even
The data
different
quality should be
different
better.
technologies within the same modality. There's no head-to-head to see which system works better, which technology works best.
Prolon is the only nutrition program patented to support longevity, health span, and protect lean body mass through cellular rejuvenation. This 5-day fasting mimicking diet keeps your body in a fasting state while allowing you to eat nourishing foods. Over 5 days, your body is rejuvenated at the cellular level, supporting fat loss with muscle protection, boosting energy and mental clarity, and giving you a complete body reset. Your kit includes everything you need for the full 5-day transformation. Click the link in the description to learn more and see our partner pricing.
Right. No, nobody's done a head-to-head and say, okay, we're going to randomize the next 100 patients to HIFU versus IRE for apical lesions, for example, which is really the way you would want to do this, the research going forward, to really prove that one is better than another. Then there's TULSA, which is laser energy directed from the urethra. There's interest in using a version of aquablation, sort of water therapy is being used for BPH. There's all kinds of other technologies out there. There's radiation oncologists, Yeah, that's exactly that. Right. The Resume, that concept is out there as well. Again, this is a BPH technology that's being considered for focal therapy. Radiation oncologists out there, there are some that will do focal radiation therapy. And there's even a couple case series of doing a partial prostatectomy, which...
For prostate cancer as well? I know for BPH.
No, for prostate cancer. That is out there. I want to say Detroit, I think they've done a couple small series. Don't quote me on the site, but this was an abstract at the AUA last year. A lot of us would say that's a little bit out there, but listen, it's...
Well, HIFU was a little bit out there as
Exactly.
well.
No, exactly.
Everything
So,
was a little bit out there at some point.
Exactly. That's exactly right. So what is crazy today is at the cutting edge tomorrow and a standard of care on Thursday, depending on how the data shake out. So the key thing is that these be studied properly, that, if you're going to do something that is at or beyond the bleeding edge, you have a very clear plan for collecting clinical outcomes properly. That includes a biopsy a year. You've got to track patient-reported outcomes religiously. You've got to have tissue. You've got to be thinking about what correlative biomarkers you're going to look at. This all has to be done carefully and well. And the state of the evidence, I would say, is slowly improving in focal therapy. It's still behind where it needs to be, but it is getting better.
I can't foresee there being a head-to-head study for a long time. And if there's a head-to-head study, it's probably two technologies or two types of focal, and then we don't know how that compares with all the others. Um,
Look, I wouldn't be that pessimistic. There is interest, and as you know, we're getting these multi-center consortia together to try to go at these questions. And there have been trials of focal therapy versus prostatectomy. I think it's a complete waste of time because we already know the answer for sure. Before you enroll a single patient, quality of life will be better than the focal therapy arm compared to surgery, without question. Also, without question, you will not get the oncologic answer for 10 to 15 years, if not more. And that is not the duration that these studies are being planned. So that design makes very little sense to me. I'm much more interested in the idea of active surveillance plus minus focal therapy for men who are marginal candidates for active surveillance. You know, most of us would say we should not be
like
doing
low
focal
risk
therapy in grade group
Gleason
ones.
7s, 3+4s, GG2s, like those.
Not grade group ones. You know, it's focal therapy is no less overtreatment for a grade group one than surgery and radiation are. The goal is taking patients who are borderline, so a sizable grade group two, who have maybe even a little bit of grade group three, maybe have adverse genomics. You know, things are not, this is not a chip shot for focal therapy and is almost certainly not a great candidate for surveillance. This is where we really need to be, you know, studying the modality. And this is where I think randomization makes a lot of sense. Can we actually avert progression to radical therapy? And can we improve oncologic outcomes?
Until then, it used to
Yeah.
be, over 20 years ago, radiation or prostatectomy. Those are your two options.
Yep.
And that's it.
Yep.
Now it's, radiation, maybe surgery, five different approaches and techniques in surgery, about 5 types of radiation therapy. I don't know, where are we with focal? It's like I lost count. I don't know if IRE is FDA approved yet. Number 6 there. How is one, right? We always talk about the proactivity of the patient, mutual decision,
Yep.
right?
Yep.
Informed decision. How is the patient supposed to say, oh, yeah, I'll do IRE or TULSA or HIFU versus the other? How are they supposed to know?
It's really difficult. And, you know, I would say the key thing is you've got to get a consultation at a center of excellence, either a cancer center or some other practice which has a real focus in prostate cancer. And you've got to get a urologist you trust who is not married to a technology. So there are the old cliche about you give the boy the hammer and the whole world looks like a nail. There's a lot of those folks out there. Somebody buys a shiny new machine, whether it is a proton accelerator or a HIFU machine or a robot, and a surgical robot, and all of a sudden, this is what they want to use to treat all the cancers. And one of the most important things that we do at the UCSF Cancer Center and most other cancer centers is the initial counseling decision. Obviously, we put a ton of focus on surgical quality, surgical outcomes, high quality outcomes after radiation therapy, being very careful about how we do focal therapy. But at least as important, if not more important, is the initial counseling decision, helping the patient get to the right decision for him about how we're going to manage this prostate cancer. Does it need treatment? If it does, how urgent is that? Is focal therapy reasonable, either as a definitive treatment or potentially as a way of kicking the can down the road several years? If we're talking about definitive treatment, when are we talking about surgery or radiation or a combination of the two? The technologies make less of a difference than we all want them to. Robotic surgery versus open surgery, obviously much less blood loss, faster recovery, but at the end of the day, the surgeon makes far more of a difference than the platform. Radiation therapy, we can do IMRT, we can do SBRT, we can do seed implant, HDR brachytherapy. God forbid we would do proton therapy for prostate cancer, which should basically
So
never be
what's
done
the
for
deal
cost
there?
reasons.
I know. So I'm
Yeah,
trying to get a
yeah,
proton therapy radiation
yeah.
oncologist. None of them accept to
So
come
you
on the
should get
pod.
either Jason Stasiu or Michael Zalewski, who
I try to get
are,
Michael Zalewski, who is at NYU, and he said yes
yeah.
many times. But I think
So,
I'll
yeah,
just keep pinging.
these are two folks who have been very thoughtful about it, very academic about it for a lot of years. And Jason actually ran an honest to God RCT of proton versus photon
Can you?
therapy. He ran a great randomized trial in kind of low and intermediate risk disease, which I believe has been presented but not yet published, which showed very little difference. The problem is, you know, it is very, very generously reimbursed by CMS and other payers. So, you know, every center is built proton centers. God help us, UCSF is building a proton center, and they swear it's not for prostate cancer. But the volume of other cancers that you need, there are definitely cancers out there where proton therapy is clearly better. And in proton therapy, in prostate cancer, it is clearly not better. So the problem is you've
Very
got this huge
expensive.
incentive. It's very expensive. Building the equipment, buying the equipment is very expensive. And then the charges to insurance are very high. So once you've built this machine, or bought the machine, there's a massive incentive to use it. So, you land at Newark Airport, there's a billboard for proton therapy. There used to be a billboard for Samadhi surgery. There's a billboard for this, a billboard for that. This is not how we should be doing things in this country. We are one of only 2 countries on the planet that allows direct to consumer advertising in healthcare. It's a travesty. It drives up costs. It drives confusion. It is an absolute mess. And we can thank the Supreme Court and their complete gross misinterpretation of the Bill of Rights for that.
Yeah.
Nobody ever intended corporate speech to be the protected speech here. So, we're in that situation though. So it is now our job in urology, radiation oncology as well, but particularly urology, because we see the patients first, to have an honest conversation with the patients about what their goals are, what our goals are in treating prostate cancer, and in sorting through all the advertising and all the noise around modalities. Because at the end of the day, what matters far more than the modality is matching the right patient to the right overall treatment. So surgery, radiation therapy, focal therapy, that is a category that's almost a philosophical approach to the cancer, active surveillance being the other one. That initial conversation is infinitely more important than robot versus open, HIFU versus IRE, proton versus brachytherapy.
Good. Yeah, great point. So what kind of focal therapy do you do most, and what are your plans? Are you going to expand? Are you going to do 3 eventually?
Yeah.
What do you do? What's your program like?
Yeah, we still do a little bit of focal cryotherapy. We're doing mostly HIFU. I think that's the large majority of what we're doing. And as I mentioned, Taudwin is now doing selected IRE, mostly in salvage cases, so patients that have recurred after radiation therapy, or for cases where the tumor is at the apex, which again is sort of a trickier spot for HIFU. We have been, there's conversations with the TULSA folks. There's a challenge in terms of how many of these technologies do you really need at a given center? The capital investment is not nothing. To buy another machine for a couple $100,000, is that really going to be a real value add above and beyond what we've already, invested in? There are certainly centers out there that have 6 machines, and there's a lot of discussion in terms of, okay, well, who's going to get TULSA versus HIFU versus cryo versus IRE? Again, I think I would certainly not want to suggest that every center needs 4 different machines to offer 4 different modalities. I think, again, what is much more important is figuring out who should be getting focal therapy in the first place. So, will we go down the path of looking at I forget what they're branding it, the vapor successor to Resume? All these things that are in the pipeline are all interesting. But, is any of them, I'm not aware of any of them that's going to be a major game changer over what we currently have, as far as I've seen. Because again, the question is much more about, can we define a treatment volume that will include the cancer and ablate that zone reliably with minimal harm to the surrounding structures, which are only a couple millimeters away? That remains our big challenge. So, and whether you're causing heat or ice, whether you're using electricity, delivering energy down to that sub-millimeter level of precision, that is what's still fundamentally the challenge.
Do you suspect that many of the more modern types of BPH treatments will eventually go into prostate cancer? So we already got Resume, HOLEP, aquablation.
Yep.
Is that where we're going?
I mean, they want to. Obviously, once you've built a technology like Resume, sure, wouldn't it be nice if we can just ablate, instead of just ablating the central zone, go a little further and ablate into the peripheral zone? Again, is there a hypothetical advantage to doing that over an existing transurethral technology like TULSA? Not that I necessarily see. Now, this is the kind of thing where you would market to a practice. Listen, you can buy 1 machine and treat both BPH and prostate cancer. I think that would be the hope. I'm a little hard pressed to see from a mechanistic standpoint how any of these is going to be better. HOLEP definitely got its place for very large gland BPH management. And yeah, in theory, you could keep carving out with the laser all the way up to the capsule of the prostate, but that is going to have its implications for quality of life. As it is, HOLEP can have higher rates of incontinence than BPH in certain contexts, than TERP in certain contexts.
Learning curve, I've heard too.
Huge learning curve. And nobody has shown me a path to like HOLEP the peripheral zone of the prostate to try to do something focal. So I think I'd be hard pressed to see that kind of making its case. And again, there is this argument, if you really know where it is, okay, go in surgically cut it out, or put in 12 brachytherapy seeds instead of 100 and just ablate this area. All these things are possible. I know focal therapy makes very little. Focal radiation therapy does not make a whole lot of conceptual sense to me because, again, if you know your target volume, why not do something ablative rather than have the relatively long wait for the radiation to have its toxic effect on the cancer, et cetera? Plus, with focal radiation, you're going to be giving a sublethal dose to the rest of the prostate. Is that going to actually drive development of higher grade cancer in the future? Who knows? These are all totally unexplored
Right.
questions. So I think you're absolutely right that we are going to see more and more technologies kind of vying for attention in this space. What I would love to see, the FDA has tried to put together a framework for research in this space, and even that has not been easy, right? You would assume, like I said before, that the gold standard should be an RCT against existing standard of care. But for the reason that I just mentioned, that is actually not the right way to answer the question, because we know focal has less quality of life side effects than radical therapy, without question. And we also know that it's going to be really hard to prove oncologic equivalence unless you are prepared to do a 15-year study, which nobody wants to do right now. 15 is probably barely long enough. Protect 10 years was inadequate. 15 years is barely adequate. They are, I think, gearing up to look at 20-year outcomes. That's what we're talking about for lower risk disease. It's a long road with prostate cancer. So we need a consistent framework that will allow us to compare modalities one versus another, that will allow us to really think about optimizing the space for focal therapy. And there really does need to be further progress in imaging. Current sort of PIRADS version 2.1 plus minus ultrasound is almost certainly not good enough in terms of defining the space. Modern MRI, whether that is these additional sequences like RSI that I mentioned, whether that is bringing AI into the radiology conversation to, again, try to do a better job identifying the target volume, maybe incorporating AI into the actual treating platform such that you'll have some AI readout on actually the way the tissue echo texture changes in real time. We can see that qualitatively while we're doing HIFU, for example. I could imagine some sort of real-time AI actually customizing the delivery of energy in real time to make sure the tissue is getting completely ablated out to exactly the margin we define. All these things are at least hypothetically possible in the future. So
Oh yeah,
there's a
come
lot
on.
to come.
UCSF in San Francisco. You guys can't be in the forefront of all this.
Oh
Yeah,
yeah,
I would
well
assume
we
that
are.
you guys
There's a lot going
there's
on. It's a
there's
lot
things in the
happening.
pipeline.
Yeah.
So location. Let's stick to HIFU because it seems like that's where you and your group have the most experience at this point. HIFU probe goes in a rectum, about the
Mhm.
same size as the biopsy probe or different?
It's larger than the biopsy probe. Patient is under general anesthesia for this, but yeah, the ultrasound probe, it's the same idea. It's a transrectal probe that is putting out energy waves, but they are, as the name implies, much higher intensity. So it's a larger probe
Sure.
under anesthesia.
How far can you go? So, right. So
Yeah.
I would think, so you already said, some areas on the apex may be difficult. How far can you go to hit a tumor when you're doing HIFU?
We can get all the way to the apex of the prostate. The challenge is that treating a volume of cancer with a good margin around it at the apex has a risk of delivering quite a bit of heat energy to the urethra itself. So we worry about urethral toxicity at that location. Some people do it pretty routinely. We've been somewhat cautious about it. The other location that can be difficult is the anterior prostate in somebody with a very big prostate, because the whole concept with HIFU is delivering radiation in kind of you're starting out with an arc and trying to focus the sound waves down to a very small volume, a very precise volume. And the farther away your target is,
How
not
big
from
is
the
how big
anus in
is
terms of
how big
distance,
is
but from the,
I'm sorry.
so how far,
Okay,
how
I'm
big is too
sorry.
big? Yeah.
Lost
So
you
it's
there.
not, it's
Sorry.
less about the volume of the prostate than it is the distance. Once you get to 4 or 5 plus centimeters from the rectum, that's where
Mm.
you can start to get challenges in terms of focusing sound waves to the anterior prostate. So it's not
So
to
in
say
terms of
there's a
just
60 gram
prostate
cutoff or 100 gram
volume,
prostate. It's
right?
less about the volume than the distance, because obviously volume is 3 dimensions. Some people grow a prostate that is particularly long. Some grow a prostate that's particularly tall. So it's getting to an anterior lesion in a tall prostate, if you will, that can be the bigger challenge.
And the question I ask everyone, I asked Arvin George, I ask everyone
Yeah.
is, they come in, it's a Gleason 8, PSMA is negative, MRI shows it's encapsulated. Genetic score says whatever it says is probably high risk.
Yeah.
Maybe one or two cores are found Gleason 8.
Hmm.
And the patient is well informed because he listens to the Dr. Geo Prostate podcast. And he says, look, I know this is not standard. I know this
Yeah.
has not been studied, but I'm working with Dr. Geo doing very aggressive lifestyle interventions. I
Yep.
really want to do HIFU. I'm not going to take out my prostate. I'll sign the dotted line if I have to.
Hmm.
Can you please do HIFU on me?
Yeah.
Your answer.
Yeah. So look, patients have agency, and a lot of things you said in that prompt that are really important. Well informed. How I would in a patient like that, I would absolutely insist that they have had the radiation oncology consultation, that they've seen at least one urologist, that they've kind of really thought through all the possibilities here. Now, there's a lot of devil in details here. So, first of all, just the fact of Gleason 8. There's a whole spectrum even within Gleason 8. Like obviously we call that high grade, but the fact is, first of all, the pathology standard is we call the case according to the worst core. So it's certainly conceivable that person, we see this all the time, that person has 4 cores of 3+4, 1 core of 3,3, and then there's 1 core that was 4+4, and it's only a millimeter of tissue. And now we're calling the whole case a Gleason 8. So in my mind, that is overdiagnosis. I think of that as a 3,4 or at worst a 4+3. And I would definitely offer focal therapy to that person,
Because of the
especially if the
volume
genomics
of
are fine.
that Gleason 8 tumor?
Yeah, because that's somebody. Because if I tell that patient, look, if we took out your prostate tomorrow, what are we going to see? We're going to see mostly 3 with a little bit of 4. By definition, that's a 3+4, not a 4+4. Okay, so and they actually did a poll of the SUO years ago. About 60% of the membership answered that they follow the ICEP convention. About 40% do what I just described, which is try to get a holistic sense of the whole tumor by looking at all the different biopsy cores. So that patient, I would say, is a candidate for focal. Now, let's say it's a real Gleason 8.
Yeah.
So it's 4 cores in this lesion, and they are all 4+4. And the genomics, we do look at the genomics. If his genomic score was in the 90s, and I'm not saying high risk, Decipher's threshold is a 0.6. 0.62 is very different from 0.92. So if it's 0.6, I would say, listen, this is not what I would first recommend to you. There are risks here, but it's probably reasonable. If you want to do focal therapy, and we're going to follow this thing really carefully, that guy is on active surveillance forever. We definitely do the biopsy in a year. It is a very high possibility that we're going to be doing more in the future. It is not unreasonable. Now, if his Decipher was in the 90s, or let's say it was, a large PIRADS 5 lesion with, 2 centimeters of contact with the capsule where there might be microscopic extracapsular extension, plus the Decipher was bad, then I'm really going to recommend away from focal therapy, partly because we have to manage the lymph nodes too. So even if a PET scan is negative, there could be microscopic nodal disease in somebody at that level of risk. And I would say if you're going down the radiation path, you need pelvic radiation. If we're going down the surgical path, we would do a lymph node dissection. The people that we see fail focal therapy in that sort of a risk stratum often fail in the nodes or in the bones. And we need to really treat this as a real cancer. So, would I say absolutely not? Probably not, but it would really not be my recommendation. I have in the old series of focal cryotherapy at UCSF, this was mostly Ketsuba Shinohara's. There were about 120 cases. We had 3 cases of metastatic progression, one of which was a patient I sent to him early in my career. And it was exactly that situation. It was a patient actually with a 3+4, MRI visible, organ confined, with a really bad genomic score. Very early days of genomics, and we didn't pay much attention to it. Patient got focal therapy. Biopsy at a year was negative, and then he showed up with bone mets, 2 years later. So would we have averted that by doing surgery or radiation therapy? Very hard to know. It is entirely possible that those microscopic cells were already out at the time of diagnosis, and surgery wouldn't have made any difference. On the other hand, it's possible that maybe there were 3 cells in a lymph node that we could have excised and could have achieved a cure in that setting. So those are not common. And that is not the kind of case that we want to set policy on, but it's the kind of case that we need to keep in mind when we talk about pushing the envelope for focal therapy. There are people out there, very respectable, high volume urologists that do offer focal therapy all the time to high volume 4+3s to low volume 4+4s. I'm not really in that camp personally, and I think it's sort of a minority of the focal therapy community that do that. But listen, nothing can yet prove that they are incorrect. So, the patient, if
or
he's really
correct.
well informed, we can take a deep breath and try it. But, with the understanding that this is very likely a first step in the treatment journey and that more is to come, and that there is a risk of missing the window of opportunity for cure. That risk is not high, but it is definitely non-zero.
And do you think there will be a time where we will look at Gleason 9s, low volume Gleason 9 for focal? And here's why I keep pushing this issue. Millennials are turning the older part of the millennials, they're like 44 years old,
Yeah,
right?
yeah,
So they're coming. And based on how I think they work and how their psychology works and how they function, they're not getting their prostate removed with a Gleason 10. I mean, that generation, hopefully they'll go see somebody like reputable like you. They even have trust issues with MDs and et cetera. So let's just say somehow or another they get a PSA is very high and they'll go see someone. I just can't see them getting their prostate removed, even if it's the right thing. So is there possibility, are they looking at higher risk disease and
yeah.
focal therapy?
I mean, there's a lot there. So first of all, the most important thing as this generation is hitting their mid-40s is to get a PSA, because this is all an irrelevant conversation
Yeah.
if they show up with metastatic disease at 60.
Yeah.
And the rates of PSA testing under age 55, under age 50 are still way, way too low in this country. And I would emphasize every guideline, with the exception of the USPSTF, which is currently reviewing their guidelines, every other major guideline recommends a baseline test at 45, below which the PSA should be under 1, not 4, but under 1. A PSA in the 2 to 3 range in your 40s or 50s is much too high and should be chased down. So get a baseline of 45. Risk factors like black race, family history, certainly anything genetic like a BRCA mutation in the family, get a baseline at 40. So that's the first
why
thing to say
not?
there.
Why not? I get a baseline if I can, if they're coming to me
Yeah,
at 40,
yeah,
everyone.
yep.
Baseline. It doesn't
Yeah,
matter.
listen,
I mean,
there's a lot to be said for it. Most guys at 40 are not even seeing their doctors. So, so it's the opportunity to capture them is not always that high.
in 1 week, I saw 3 patients, 45 years and younger, aggressive prostate. Now, I sporadically see 3 maybe a year.
Yep.
This just happened. So there's going to be more and more of this. So if you
There
get
is going
a
to be more
PSA
and more
at
of them.
40, you can probably, at least you have a baseline.
There is a story that we keep seeing about increasing rates of cancer in younger people. And prostate is part of that story. There is definitely an increase in the rates of aggressive prostate cancer in younger people. I totally support a baseline of 40. The guidelines don't, go that low because there's really no data below 45. But there's not much there's not a tremendous amount of reason not to, as long as you've got somebody that's not going to chase down an overdiagnosis, overtreatment pathway
Sure.
if the PSA is equivocal. So baseline of 40 makes perfect sense. But getting back to the guy who's now been diagnosed in his 40s with, this was an aggressive one, but fortunately we caught it early because he did get a screening test. There's a lot of molecular work to do and research to be done, which is why we got to keep funding the NIH, for the love of God, because we need to figure out which of the Gleason 9s are fated to spread early. And this is the really tricky thing. So one of the best oncology lectures I've ever heard was at MSK by a breast oncologist who had this whole thesis that cancer is not a problem of growth, it is a problem of spread. And the notion here is that some of these cancers have the biologic capacity to get out into the bloodstream very early. And there are men who have a 1 centimeter Gleason 9 prostate cancer. We do surgery, we take it out, PSA goes to 0, everybody celebrates. And 5 years later, there's a bone metastasis, meaning that there were metastatic cells already out there from a 1 centimeter, tiny little primary tumor, but it grows so slowly, it took a long time for them to show up. So when you say Gleason 9, that's what we worry about. Okay, we worry that if we mess around with this, there is a real chance of missing the window of this spreading. Now, without question, when we look at so-called aggressive prostate cancer, so the 10s, the 9s, the 8s, the so-called unfavorable histology Gleason 7s, that's things like expansile cribriform, intraductal patterns like that. These are the ones that can cause a problem. Okay, if you have anything less than that, they almost never cause a problem. So grade group 1, we shouldn't even call cancer. A lot of the grade group 2s, fused gland subtype, poorly formed subtype, there's histologic details that really matter here. A lot of those we can follow from a pretty healthy distance. The ones that matter, some of them grow aggressively but don't spread. Others spread very early. We have a lot of work to do in terms of molecular analysis to try to figure out which ones are aggressive but are still years away from metastasizing, as opposed to which ones are probably already trying to send out scouting cells to see if they can find a home in the bones. And ultimately, if you want to talk about focal therapy for high-grade cancer, we need that evidence base. We need the correlative science to say, okay, listen, this one's Gleason 9, but we have a fair reason to believe that it is not sort of incipient molecular changes all over the prostate, and this is not about to explode. And if that's the case, then okay, let's very cautiously think about focal therapy with an aggressive margin around it, et cetera, as opposed to other ones where the answer is really going to be, we cannot mess with this one. And I would say, too, that there is a difference between asking a 42-year-old, what do you think hypothetically about a prostatectomy, and taking a 52-year-old who has just been diagnosed with a Gleason 9 cancer and has little kids at home and is kind of staring at the abyss. That is actually a very different conversation. And I think as the millennials age, they're going to be facing that conversation just like, Gen X did before them. So, that will all be an evolution. And it's incumbent on us to have the right tools and the right vocabulary to have the right conversation with them about what cancer is, what it is not, what treatment entails and what it does not, and where you need to get treatment, where and how.
Genomic score, does it help you with a Gleason 9? So low risk Gleason 9?
Yeah.
Is that?
Yes.
Yeah.
Yes. I think, if you're looking to rule somebody in for focal therapy, or when we try to rule somebody in who's got a 4+3 fractive surveillance, if they get a low genomic score, that is relatively reassuring. The scores are definitely not perfect. We can undersample the cancer and send the genomic score on maybe not the worst part of the tumor, but on average, a low genomic score is reassuring. And it's relatively unusual that we see bad pathology in a low genomic score or favorable pathology in a high genomic score. On average, when we see that, the genomics actually tend to win. The genomics tend to be right. Now, I say that based on prostatectomy tissue more so than by biopsy. So again, the biopsy might have missed something worse in the cancer. But, a low genomic score would, on average, help me rule somebody in for focal therapy. But that is opinion. That is like art of medicine. I don't have a lot of data to say that is definitely safe.
Understood. Matt, thank you so much for
Yeah,
being on.
it's a pleasure.
It's always such a pleasure. And, I thought we were going to see each other a week from now at the NYU conference, but it's all right. I'll see you on video. It'll
Definitely.
be
And the
probably
following year for sure.
a similar format.
Yeah.
Enjoy your get together with your classmates from college.
Yeah, thanks.
Final words, and how can people find you?
Yeah, easy to find. Matthew.Cooperberg at UCSF.edu, on Twitter at Dr._Coops or X. And the final word is get a PSA test in midlife, please. Between 45 and 55, it should be under 1. And if it's higher than that, talk about workup. Think about what the implications might be. This does not mean you need a biopsy. If we find the cancer, by no means does it mean it needs treatment. But if we find a high grade one, you need to find that early while it is still curable.
1,000%. Matt, thanks so much.
Great to
I
see
really
you.
appreciate you. Thank you.
Anytime. Take care.
Thank you, everyone, for watching the Dr. Geo Prostate Podcast. It's such a pleasure to have the best of the best. We always try to get the best of the best to come on. Thank you. Keep watching. We have more to come. See you next time. Much love. So long.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more.
If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgeo.com. I'll see you next time.